This is my first presentation outside. So I'll start with my presentation now. I'm going to speak about ocular myasthenia. Mainly, I'm going to discuss about the differential diagnosis and the treatment part. Little bit about history of myasthenia because I found it a little bit interesting. Thomas Willis was the first person to describe myasthenia gravis. He is the same person who had discovered the circle of Willis. And he had several patients with drooping of eyelids, and he also had patients those who had difficulty in speaking, especially after speaking for prolonged period of time. So clearly he was describing about myasthenia gravis. And this was the first ever case of myasthenia gravis which was reported in literature. He was a tribal chief, and one interesting part about this case is he was having attendants to lift his ptotic eyelids. And after rest, his weakness significantly improved. So definitely he was suffering from myasthenia gravis. He had both ocular features and generalized features. Now coming on to Mary Walker. She is a very important person in myasthenia gravis because she was the first one to tell that there is some association between myasthenia gravis and neuromuscular junction. Something is happening in the neuromuscular junction level. And she was the first one to tell that the signs and symptoms of myasthenia gravis is very similar to that of plant poisoning curare. And she was the first one to use neostigmine in myasthenia gravis. And the first ever case publication of myasthenia was from Guy's Hospital, London. So many case reports are published as an initial case report from Guy's Hospital, London. Subsequently, many hallmark publications came on myasthenia gravis. Initially, myasthenia gravis was called as Erb's Goldflam disease, and subsequently, it was named as myasthenia. So the word myasthenia gravis, the interesting part is the word is derived from both Greek and Latin. Myasthenia means muscle weakness and gravis means severe. So myasthenia gravis is severe muscle weakness. So as we all know, myasthenia gravis is an autoimmune disorder where the antibodies are targeted against acetylcholine receptor antibodies. It is a postsynaptic disorder. One important differential diagnosis for myasthenia gravis is Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is a presynaptic disorder. How to differentiate myasthenia gravis from Lambert-Eaton myasthenic syndrome? So in Lambert-Eaton myasthenic syndrome, the autonomic features will be there. Post-exercise facilitation will be there. And one more thing important clinically, how to differentiate myasthenia from Lambert-Eaton myasthenic syndrome is isolated ocular involvement will never occur in Lambert-Eaton myasthenic syndrome. Whereas isolated ocular involvement is the most common presentation seen in more than 70% of the cases in myasthenia. This is how one can differentiate myasthenia from Lambert-Eaton myasthenic syndrome. The age group also differs. The gender also differs. Myasthenia, actually it is bimodal, more common in female in younger age group. Whereas Lambert-Eaton myasthenic syndrome is more common in the elderly population, males are most commonly affected, and 60% of the cases it is associated with small cell lung cancer. And 90% of the cases of Lambert-Eaton myasthenic syndrome will have antibodies positive for voltage-gated calcium channels. So isolated ocular involvement never occurs in Lambert-Eaton myasthenic syndrome. They can come with ocular presentation, but usually generalized weakness will also be there in Lambert-Eaton myasthenic syndrome. So what are the antibodies which can be positive in myasthenia? So nowadays, recently, many more antibodies are getting discovered. So there are variety of antibodies in myasthenia. Acetylcholine receptor antibodies, MuSK antibodies, and anti-striational antibodies are there. So how to increase the sensitivity of diagnosing myasthenia? So if you do a combined panel, if you're doing all the antibodies together, you can increase the sensitivity of your diagnosis to 94%. So if ACHR is coming negative, do the other antibodies also so that you are improving the sensitivity of your diagnosis. Why the extraocular muscles are most commonly affected in myasthenia? Because in the extraocular muscles, the synaptic folds are less, the receptors are less, and not only that, it is more prone for destruction. That's why the extraocular muscles are very commonly affected in myasthenia. We can classify myasthenia like this. It can be called as early onset, late onset. It can be called as seropositive. It can be called as seronegative. It can be positive. It can be called as ACHR positive, MuSK positive, like that. It can be classified. So this slide is just to show the difference between myasthenia gravis and Lambert-Eaton myasthenic syndrome. The first picture clearly shows that it is a postsynaptic disorder, and the second one shows Lambert-Eaton syndrome, where the antibodies are affecting the presynaptic area. So myasthenia gravis is a chameleon. It takes various forms. It can present like any other multiple disorders. It can mimic. So the first one is in this picture. You can note that there is ptosis and down and out eye. So always look at the pupils to find out whether it is surgical third nerve palsy or medical third nerve palsy. So she is a case of third nerve palsy. It can mimic like myasthenia. And anyone can tell the diagnosis for the second patient? Hornus. There is mild ptosis and meiosis. So always look at the pupillary abnormality. Don't miss out that. And suppose when a patient is coming with bilateral ptosis and bilateral extraocular movement abnormality, you need to think about a brainstem disorder also. So a lot of cranial neuropathies, brainstem disorders, muscular dystrophies, myotonic dystrophies, lot of things can mimic like myasthenia. So in this picture, you can make out that there is bilateral ptosis, ipsilateral third cranial nerve palsy, and contralateral superior rectus palsy, and pupillary abnormalities. So what is the diagnosis? Yeah, it is nuclear third nerve palsy. Nuclear third nerve palsy can mimic like myasthenia. But suppose if it is hyperacute onset, it can be because of stroke. Suppose if there is a malignancy, breast cancer, which had metastasized to the midbrain, it can present in a chronic insidious way. So it can mimic like myasthenia. One tend to get carried away by bilateral ptosis and bilateral extraocular abnormalities. So always think about nuclear third nerve palsy also. So one of the common muscles to get involved in myasthenia gravis is the medial rectus muscle. So it can mimic like pseudo INO kind of pattern. So what is INO? Anyone? INO? Internuclear ophthalmoplegia. So INO, it can be because of variety of causes. It can be because of stroke. It can be because of demyelination. It can be because of tumor. Can be because of radiation, can be because of infective granulomas. And INO itself can be classified into anterior INO and posterior INO. So what is anterior INO? Anterior INO is ipsilateral adduction restriction with contralateral eye abduction nystagmus. So this is a case of INO, which can mimic like myasthenia. So if it is hyperacute onset with vascular risk factors, history of smoking is there, history of alcohol intake is there, dyslipidemia is there, patient is an hypertensive, always rule out stroke. And the prognosis of INO is very much favorable in vascular etiology. It resolves usually within 3 to 6 months. The prognosis of INO is very much favorable. And this is a case of posterior INO. What is posterior INO is exactly opposite to that of anterior INO. The patient will be having ipsilateral abduction restriction with contralateral eye adduction nystagmus. And whenever INO is there, please look for convergence also, whether convergence is intact or not intact. Suppose if convergence is not intact, then the lesion is there in the midbrain. Suppose if convergence is intact, then the lesion is there in the pons. So what is wall-eyed INO? Otherwise, it is called as Webino syndrome. So patient will be having bilateral adduction restriction and abduction nystagmus. Rarely myasthenia can present like Webino kind of picture. This was an interesting article which was published in 2018. This particular patient had Webino kind of picture, but she was positive for myasthenia. She was treated for myasthenia, completely recovered after treatment. The second image you can see, she got completely recovered. So whenever a patient is coming with a facies like this, a myopathic facies, fish-like open mouth appearance is there, ptosis is there, baldness is there, and hatchet-like facies is there. Always consider myotonic dystrophy. Don't jump into conclusion that after seeing the facies, don't jump into conclusion that this is myasthenia gravis. Always ask in history regarding grip myotonia, cold-induced exacerbation, and difficulty in opening the mouth after eating ice cream. And just do simple examination. Just do percussion myotonia. just percuss over the thenar eminence and elicit for myotonia. It can be myotonic dystrophy. Simple bedside examination, you need not do any genetic testing to confirm the diagnosis. Anyone can tell this is a tough case, but so this particular boy is having one-sided ptosis and myopathic facies is there. Fish-like open mouth appearance is there. But on examination, he is also having winging of scapula. So simple examination, you need not do any genetic test. So this is a case of facioscapulohumeral dystrophy. Asymmetry is the rule in facioscapulohumeral dystrophy. That's why this patient is having, usually in myotonic disorders, in myopathic disorders, you tend to get bilateral ptosis. But in this case, clearly you can make out that the ptosis is unilateral and asymmetry is the rule in FSHT. So finally turned out to be FSHT. Rarely LGMD, limb girdle muscular dystrophy, can also present with bilateral ptosis and ophthalmoparesis. So an elderly male presenting with bulbar weakness, facial weakness, and ptosis is there. So what differentials you would consider? Yeah, first thing is oculopharyngeal muscular dystrophy, and then myasthenia gravis. And one more thing is there, MND. But in MND, extraocular muscles will never get involved. Suppose if an elderly patient is coming with bulbar weakness and facial weakness alone, you can consider three differential diagnoses. It can be OPMD, it can be myasthenia, or it can be MND. But definitely this is not a case of MND because extraocular muscles are involved. A 30-year-old female coming with bilateral symmetric ptosis, chronic progressive ptosis, and ophthalmoparesis, no history of diplopia, no history of fatigability, no diurnal variation. On examination, sensory neural hearing loss is there, pigmentary retinopathy is there. So the diagnosis is chronic progressive external ophthalmoplegia. It is a mitochondrial disorder. Multi-system involvement will be there. Very easy to diagnose. Do some blood investigations, do CPK, lactate, and ammonia. Look for the liver enzymes. Check for myopathy. Check for peripheral neuropathy. Sometimes they'll be having seizures also because it can involve anything in the body. It can affect the brain, it can affect the nerves, it can affect the muscles, and it can affect the liver, it can affect the heart. So they can present with dilated cardiomyopathy. They can present with conduction abnormalities in the heart. Sometimes they will be having renal involvement also. They'll be coming with creatinine 1.5 like that. Simple blood investigations will give you a clue that this is not a simple disorder. It is a multi-system disorder, probably mitochondrial. So in the first picture, whether it is true ptosis or pseudotosis, it is true ptosis because there is frontalis overactivity, there is bifacial weakness, myasthenic snarl is there. So this is a case of true ptosis. Whereas in the second picture, there is eyebrow droop sign or eyebrow dip sign. So there is eyebrow droop, which is very typical for psychogenic ptosis. And one more test you can do for psychogenic ptosis is cover the normal side. If you cover the normal side, the ptosis will improve in the other side. This is how you can diagnose psychogenic ptosis. And this was an interesting case report, which was published from Italy. So psychogenic convergent spasm. So this particular girl was initially treated as a case of myasthenia. Her antibodies were positive. RNS was positive. And in fact, single fiber EMG was positive. But finally turned out to be psychogenic. And she was responding little bit to pyridostigmine also. It was then discussed that probably it could be a placebo effect. And all these are technical errors. So clinical examination is very important in diagnosing rather than relying on investigations. So convergence abnormalities are rare in myasthenia gravis. So when you get to see, and pupillary involvement never occurs in myasthenia. So if you get to see convergent spasm, transient convergent spasm with meiosis, please consider psychogenic convergent spasm. It is one of the most common psychogenic ocular movement disorder. There is one interesting article which was published in 2022 where they had listed the list of differential diagnoses for ptosis and ophthalmoparesis, and they had described the extraocular muscles which are predominantly affected in each of these disorders. Now coming on to the bedside test for myasthenia. So the important test I'm going to discuss now. So what is Simpson test? Simpson test is nothing but you are inducing fatigability. Make the patient to look up. Ask the patient to maintain sustained up gaze for 50 to 60 seconds. There will be worsening of ptosis. What is bind fan test? Bind fan test is ask the patient to tightly close the eyelids for 30 seconds. And after that, there will be improvement in ptosis. There is another easy test. You can ask the patient to sleep for 30 minutes, and after that, the ptosis will improve. What is peak sign? Peak sign is nothing but incomplete burial of the eyelashes. And what is curtain sign? Curtain sign is a dynamic sign, and it is based on Herring's law of equal innovation. So what happens is, if you lift the ptotic eyelid, the other side automatically it will droop. So this is called as the curtain sign. And curtain sign, you can do it only in asymmetric ptosis. So coming on to ice pack test. Ice pack test is very important. Any patient suspected with myasthenia gravis, ice pack test should be done, and very easy to perform also. Keep the ice pack over the covered eyelid for 2 to 5 minutes. And after that, there will be improvement in ptosis. More than 2 millimeter improvement is considered to be significant for ice pack test. And for diplopia assessment, you need to keep for longer period of time. It is not 2 to 5 minutes for diplopia. It is 5 to 10 minutes for diplopia. And why it is so important? Because it's very specific. It is similar to edrophonium test actually. Ice pack test is similar to edrophonium test. But one of the drawbacks of ice pack test is, anyone can say one of the drawbacks for ice pack test? One important drawback is for mild ptosis. You would have encountered in your OPD also, for mild ptosis and severe ptosis, often you will get false negativity. Because the sensitivity of ice pack test in mild ptosis and severe ptosis is just 25%. Whereas in moderate ptosis, the sensitivity is 70%. That is the only drawback of ice pack test. And what is slow test? Slow test is nothing but simultaneous lip and ocular weakness. Initially, I had told about Mary Walker. She was the one to describe about this effect. So what is slow test? Anyone can tell what is slow test? So slow test is nothing but you are activating two group of muscles in the face. You are activating both the ocular group and also the perioral group of muscles. Ask the patient to do a smile-like posture and simultaneously ask the patient to maintain a sustained up gaze. So you are trying to exhaust the periocular group of muscles. After doing that, what will happen is there will be exhaustion of the perioral group of muscles also. There will be drooping of the corners of the mouth. So you are exhausting the ocular group of muscles. Automatically, the perioral group of muscles will get exhausted. And what is Cohen's lid twitch sign? Ask the patient to look downwards for 15 seconds and immediately ask the patient to look upwards. There will be a momentary lid twitch. Edrophonium test, everyone knows about it, so I'm not going to discuss about that. And blood investigations, as I told before, do combined antibody panel. It increases the sensitivity of diagnosis to more than 94%. Coming on to RNS. RNS is a very good test. Just look for decremental response. More than 10% decremental response is considered to be positive for myasthenia gravis. What is decremental response? Compare the first CMAP and the fourth CMAP. There will be drop in amplitude. So if drop in amplitude is there, then RNS is said to be positive. One of the drawbacks again for RNS is for ocular myasthenia, the sensitivity is very less. And single fiber EMG is considered to be the gold standard for myasthenia gravis, highly sensitive and specific. One of the drawbacks again, patient should be cooperative. Lot of technical expertise is needed. Now coming on to the role of extraocular muscle imaging in myasthenia gravis. Is there any role of MRI in myasthenia gravis? Till now, the role is not established. There are some recent case reports telling that there will be extraocular muscle atrophy in myasthenia gravis, especially in severe cases of myasthenia gravis, seropositive cases, MuSK antibody positive case status, and patients who are poorly responding to treatment, there will be extraocular muscle atrophy. But whether this atrophy is really specific for myasthenia? No, because extraocular muscle atrophy will be seen in other degenerative disorders also. It can be seen in myopathies. It can be seen in muscular dystrophies. So it is not specific for myasthenia. So just I wanted to show that there can be fat infiltration within the muscle in myasthenia gravis because it is an inflammatory disorder. So automatically there will be fat infiltration. So this was a case report which just showed extraocular muscle atrophy in myasthenia gravis. Again, this is another case report which was very recently published in 2022, showing severe extraocular muscle atrophy. Almost the muscle is looking like a thin slit, and severe extraocular muscle atrophy in a chronic case of myasthenia. But definitely MRI plays a role in diagnosing certain disorders like thyroid eye disease. There will be fusiform enlargement of the muscle with tendon sparing. And IgG4 disease and infiltrative disorders, space occupying lesions, lymphoma, sarcoidosis can be easily diagnosed with the help of little bit. It gives clues in MRI. So anyone can tell me the diagnosis? No. After seeing the Gover sign, look at the face, look at the eyes. Is Gover sign very specific for Duchenne? So in the face, you can make out that there is left eye ptosis, mild ptosis, right? Right side, there is mild proptosis, correct? And myopathic facial feature is there. Little bit open mouth appearance, fish mouth appearance is there. And Gover sign is positive. Head lag, in fact, is positive. So finally turned out to be thyroid related eye disease, which was mimicking like myasthenia. She was treated for thyroid pathology. Ptosis went away. So this is a case of thyroid related eye disease. So the most common ocular manifestation in thyroid related eye disease is eyelid retraction and exophthalmos. This everyone knows, I had discussed. So again, ophthalmoparesis can happen in myotonic dystrophy also, very rare, but think about that also. And whenever myotonic dystrophy is there, look for the cataract. This everyone knows. And this is pseudo CPUO kind of presentation in myotonic dystrophy. So whenever you see chronic symmetric ptosis and ophthalmoparesis, don't think about CPUO or myasthenia alone. Think about other muscular dystrophies also. And prognosis. Coming on to the prognosis of myasthenia, early the diagnosis, better is the prognosis. Coming on to the treatment part of ocular myasthenia, better to treat ocular myasthenia with immunomodulators because 80 to 90% of the cases they progress to have generalized myasthenia. And when to consider surgery in myasthenia. So when the ptosis and strabismus is not responding to treatment properly and if it is remaining stable for more than 2-3 years, then you can consider surgery. When to consider thymectomy in ocular myasthenia? The role of thymectomy in ocular myasthenia is still controversial. Thank you.